John, hello.
Hello,
Good to meet you.
and you.
Thanks for joining us here. Now, we're going to have a chat about your exciting developments over in Norfolk and the development of or startup of a Palforzia clinic. Before we do that, may I ask you, John? We kind of know each other and we've had a chat. The audience won't. Where are you? What do you do for a living?
Where am I? That's a really good question. I'm John Chapman. I'm a consultant paediatrician at the James Paget Hospital in Great Yarmouth, which is on the coast in Norfolk, very beautiful area. So I've been here for 22 years doing pediatrics and particularly allergy, and that's kind of my backstory.
Super. And I had a call with Adam Fox, and there's a separate video about immunotherapy. But Palforzia is a recent medicine, if I'm correct in saying, and it's all kind of, there's lots of talk about it and lots of hope for the future with other similar sort of medicines being developed. Can I challenge you in a couple of sentences, really? What is Palforzia? Why is it the big thing at the moment?
Okay, so Palforzia is the big thing at the moment because the trials have just finished for this treatment, and it's just been accepted by NICE as a good treatment for peanut allergy. Very, very effective treatment. It's immunotherapy, which makes it sound very, very grand. It is tiny packets of peanut flour measured out to like the hundredths of a peanut, so much less than you could do on your kitchen scales at home. So really accurately measured out doses of peanut, and you start at a super low dose in hospital, and then every few weeks we turn up the dosage, and hopefully we kind of sneak the peanut under the radar of your immune system, and your immune system eventually stops panicking about peanut. And you don't react to it anymore. So that's the basic premise of immunotherapy. It's sometimes called desensitization as well, just by kind of eventually flooding your body with something that it thought was bad, and then when nothing bad happens, your immune system adjusts to that.
And this is specifically for children, am I right?
So all the studies have been done. The currently published studies are children between the age of 4 and 17. So that's kind of why it's got a license in that age group. As far as I'm aware, there's no reason why it wouldn't work in an adult, but all the studies are done up to 17. There's currently a study that we're involved in doing the younger children between the age of 1 and 4, just to kind of join it up and make it a kind of a whole child thing. Whether the license will change will depend on the results of the study.
But the NICE approval was specifically for children.
Yeah, the NICE approval is specifically for children between the age of 4 and 17. So you can start when you're 16 and 300 days, and you can carry on past 17 if you need to, but you must start before your 17th birthday.
And so you've set up a clinic specifically for Palforzia over in Great Yarmouth.
It sounds a bit random, doesn't it? So the way we got here was that we were involved in the trials for this medication,
right.
Previously called the fancy name of AR101. Obviously, they chose a better name when they brought it to market.
Palforzia is a bit of a mouthful as well.
Yeah,
not the easiest of things to remember.
It sounds a bit like one of the Avengers, doesn't it? So we were involved in the research trials at the beginning. So when this medicine was coming to market, we'd already used it on quite a few patients. We had a lot of experience. We're familiar with the protocols. So we had a relationship with the company, and they were happy for us to start doing it, because obviously they've been very, very cautious about this treatment, because if it's delivered incorrectly, people will be unwell with it and they'll have allergic reactions, and that isn't good for anybody. So they are keeping quite a tight control of this drug, and it has to be ordered through them. So you have to go to a specific center who know how to do this kind of thing safely. So We were in a position to do that. And then because the company agreed with us, we were able to start treating NHS patients with it.
We have lots of calls from our helpline asking from patients, hey, how do I get hold of, how do my child go on to Palforzia? But there aren't that many places that actually prescribe it and take somebody through that treatment.
Yeah, so I think we were the first in the NHS to do it. That's not because anybody's worried about it particularly. It's to do with the funding. So the funding would come through NICE usually. So usually when NICE approve a drug, a cancer drug, for example, they say, here's a new drug. It's a good drug. We've looked at the evidence. If you need to prescribe it, take some money out of our pot, because NICE have their own pot of money. They didn't do that with Palforzia. What they did with Palforzia, they said, these patients are coming to hospital every 2 weeks for updosing. So that will generate money for the hospital. Because every time a patient comes to be seen in hospital, the hospital gets paid for that. So you can generate your own money to pay for the medicine. Unfortunately, lots of hospitals are in what's called a block contract. So they get the same amount of money whether they see 1 million patients a year or 1,100,000 on top of it. So there is no flexibility in funding. So it's not a particularly good model for most hospitals like mine. So what I would have had to do was wait until next April and then apply to the people who run the contracts for next year and say, I would like to do this treatment next year. I didn't really want to wait till next year. I do worry about new things. If they're not picked up quickly, they go a bit cold and they get sidelined a little bit. So I pulled every string that I could get hold of. And I found some charitable funding in my hospital. So my hospital has what's called an innovation fund that can be used for setting up new services, pump priming, they call it. So I applied to them and said, this is a brand new treatment. We can start this treatment now. We can do good for these patients using this money that's come from a charitable fund given to do good to patients. And I managed to get enough money to do 10 patients.
So it sounds a very complicated way of doing it, and presumably with it being a charitable fund that's almost helping pay for the service. Presumably there's a limit to the number or where patients can get referred from. Is that restricted to the Norfolk area? Is it even tighter?
So essentially, it's children that were in my hospital, in my service. So this is money from the James Paget Hospital charity. So it didn't seem appropriate because people have given that money to this hospital to treat patients from anywhere other than this hospital. And as this is the first time we've done this, apart from research patients, we have plenty of people who are keen to start. So we didn't really have a very rigorous process this year. We do plan a rigorous process in future, but we just chose 10 random children as they presented to us and offered the treatment. Obviously, we offered it to some people who weren't keen because it is a bit of a commitment doing it, but we got to 10 reasonably easily and started them off.
So how often does a patient need to go in? You said there's a commitment there. How long's the treatment for? How frequently does somebody need to go into James Paget?
Yeah, so the treatment starts with what's called an escalation day. When you, over the course of a day, you have the tiniest amount of peanut, and then that's increased through the day in intervals of about 30 minutes to a point where you're tolerating 1/50th of a peanut. If you can't tolerate that, then you're not going to tolerate Palforzia, and there's no point in carrying on. If you can tolerate up to 1/50th of a peanut, then you come back the following day and you start on the standard treatment, which starts off at 1/100th, so half of that. So we know that you're going to be safe with 1/100th. Then what we do is you have the next dose the following day, and then you take the rest of the 2-week treatment at home. So you would stay on 100th for 2 weeks at home, and then you come back 2 weeks later, and you go up to 1/50th, and then you come back 2 weeks later. until you get up to 300 milligrams of peanut flour, which is equivalent to 1 peanut. So it's a 2-week commitment for about 12 weeks. And then you get to the maintenance dose of 300 and you stay on that and just come back and see us perhaps every 3 months. We haven't quite worked out how often that's going to be at the moment. I mean, if people are well, and we actually have quite a lot of contact with them through email, for example, then they might not need to come back that often. That's not that part of it's not been very well prescribed.
And that maintenance dose is at home. It doesn't mean that the patient needs to come in.
Yes, so they have 1 dose every week, every 2 weeks in hospital, and then the doses in between, which they take every single day, they will have at home.
I mean, that sounds very exciting. That there's kind of a hope almost that things can get better, and presumably there are other sort of medicines in the pipeline that are equally as exciting, and that these treatments are forever being developed. Do you see that there's anything else there that is not just for peanuts? Could there be something for milks? Could there be something for all of the other allergies, or at the moment is the concentration just upon peanut allergies?
So from a research point of view, peanut allergies, as far as the company that produced Palforzia, it's done. They've got their product. It works. It works really, really well. At the end of the treatment, in the studies, over half the patients that took it were able to eat 5 or 6 peanuts at the end. So
that's incredible.
Yeah. So when you get to the end of it, you will carry on eating peanut every single day, and you should be protected from contamination, for example. So you'd be really unlucky to get food that's contaminated with as much as 5 or 6 peanuts.
Yeah.
So that's the idea. It's not a cure. You don't take it for a year and then you're absolutely fine.
Okay.
You take it for a year and you carry on taking the equivalent of a peanut every single day. After that, probably in the form of an M&M or Reese's Pieces, whatever, just to keep your immunity going. But you asked me about other treatments. I know that there's a study going on at the moment looking at desensitization for cashew. There's another study just about to start. In fact, I think it's just started up north, desensitizing babies for milk allergy. So rather than our usual plan, which is to just avoid milk for the first year of life, it's introducing slightly changed hydrolyzed milk early on to try and desensitize them. So yes, we're not standing still in the allergy world. Everything changes. When I started 22 years ago, I'd make a diagnosis of, say, peanut allergy, and then say, my advice was don't eat it. And that was it. Have an emergency plan, but essentially don't eat it. Whereas now, we have lots more active treatment. We're desensitizing people. We're advising people about diet for their babies to stop them getting allergies in the first place. There's an awful lot of stuff going on.
But without wanting to raise expectations too high, these medicines do take an awful long time, don't they, to go through the trials and then through the regulatory process before they actually get prescribed. And then they, of course, they need to be approved by NICE so that we can afford to prescribe them. And then, you have to go through the mechanisms of setting up the clinics and everything as well. So it can take a very long time, can't it, unfortunately?
Yeah, I mean, that's one of the reasons I wanted to push through and have a clinic done, so that when I come to my contracting time next April, I can say to my team, this is exactly how much it will cost my hospital. And I'm in contact with lots of other hospitals in my area and around the country who will want those figures as well. So they can say, genuinely, this is how much it will cost. So hopefully we can spread this out because, it's a good treatment. So, if people want it, then it should be available. That's the whole point of NICE.
So the long-term sustainability of the clinic and being able to do what you do is there, or is it almost that kind of an annual negotiation with the hospital's board and the finance director to argue your case against all of the other pressures that are on the hospital trust?
I'm hoping it's just a one-off.
Yeah.
I don't think I could do it every year. There would probably be a limit. So, for example, we will probably say that we will do 10 patients a year.
Right.
And that's just because if we did everybody, we'd be absolutely swamped and we wouldn't get anything else done. So I work in what's called, changed its name this week, an ICB, an integrated care board or integrated care system.
Right.
So there are 3 acute hospitals in my system, and I've been in contact with my colleagues in the other hospitals, and our plan is that we will have a system-wide service. So, perhaps each hospital will pick their top 10, or as a team of 3, we will pick the top 30 in the region. And then we will work out where they have their treatment. Maybe they'll all start their treatment with me and go back to their base hospitals for the maintenance or some other system. So, we're all kind of working together to get as much of this done as people want and people need.
And I think it's great that within the NHS itself, and certainly that's something that Anaphylaxis UK wants to encourage, is that learning from each other. Is making those connections and how did you do it? How did you set something up? How did somebody else do something differently? And I think that sharing of knowledge is so very important, isn't it?
It is. I mean, most hospitals will have 1, maybe 2 people who do children's allergy. So it can be really lonely. And unless you make contact with other people in similar situations, you don't learn very much, and you carry on doing the same stuff. So we all the regions have networks, informal meetings where people get together and share their best practices, and that's one of the most useful things that we do.
John, it's been very interesting, and good luck to you developing the service further. Let's keep in touch and hear how things are, and certainly, after Christmas, maybe towards the beginning of your financial year, hear how things are going as well. But if there's anything, of course, that we can do at Anaphylaxis UK to help facilitate any of that networking, any of that dialogue with colleagues, we're more than happy to do it. But I think it's been a very interesting conversation and an exciting development of new medicines and new services. Just what's in the pipeline and what's on the horizon. It's been great to hear.
Good to talk to you.
Super. Thanks ever so much.